Today I want to talk about how we can use spirometry, which you used in class, to help us diagnose different diseases in the respiratory system. We have to pay attention to two values when we're looking at diagnostic spirometry. And in this case, all we really have to do is ask the patient to bring in a big old breath and breathe through the spirometer as quickly as possible with as much breath as possible, basically forcing as much air through the spirometer as fast as possible. And there are two values that I want to take a look at as this individual has pushed all the air through the spirometer uh, and basically couldn't push any more out at this point. One value I want to pay attention to is the forced expiratory volume in 1 second. We call that the FEV1. The FEV1 is the volume exhaled within the first second. So if I'm looking at the time axis here, the x-axis, I would look for 1 second, trace that upward to my line that is my data, and then I would look at the volume that that corresponds to. Just looking at x equals 1 and finding that value for y, we would have our forced expiratory volume in 1 second. This is always after a deep inhalation or inspiration and a forced expiration, as in we're pushing the air out as quickly as we possibly can. Another value I want to look at is the forced vital capacity. That would be the total volume of air that the patient can forcibly exhale in one breath, meaning I allow them to continue to breathe out, not just past the 1 second, and I measure the maximum value, the total volume of air that can be possibly pushed out of the lungs by this patient using this one forced breath. And you see that the FVC, the forced vital capacity, will be bigger than the FEV1, which makes sense. It takes longer than a second for you to push out air at a bigger capacity than just 1 second. So we are going to compare these two numbers to some vital information that is basically averaged across many people of many ages. So in this diagnosis spirometry, we'll have some normal values we can look at. You do not need to memorize these values. Anytime we have an abnormal value, we will be able to compare it to the normal values in the same question. But for a normal FEV1, that would indicate that the airways are unobstructed, meaning that the breath that I take can leave my lungs quickly and in a timely fashion because there's nothing in the way for them to go through. In healthy patients, this would be about 3 to 5, or excuse me, 3 to 4.5 liters in males. Sometimes 3.5 is the minimum cutoff. We're always going to think about this like an 80% rule. So even if we're outside the normal range, if we're within 80%, that's still pretty good. So it doesn't really matter if we have, let's say, 3 as our FEV1 for a male. For females, it's going to be 2.5 to 3.25. Again, 80% rule is pretty good. This is a good range, like optimal range for everyone, but if it's not entirely optimal, it doesn't necessarily mean that they have a disease. The forced vital capacity, however, means something entirely different than the FEV1. A normal forced vital capacity would indicate that the lungs are functioning well, meaning that we can bring in air and push out air just fine. As long as I have a normal forced vital capacity, I know my lungs are doing their job as well as they possibly can. And in patients, 20 to 60 range again, males, we're going to have it around that 5 liters mark, which makes sense because this is about the same number that you saw in your spirometry lab. For females, 3.25 to 3.75 of a liter, and you could probably get even up to 4 liters for that value. It again depends on a bunch of different things, such as age, such as obviously gender, such as body build, such as the actual capacity in your chest, such as weight and height, and stuff like that. So I want to take a look at this value here, and let's say that I have a patient who is experiencing some difficulty breathing, And we ask them to breathe in as much as possible and breathe out as quickly as possible, as deeply as possible through this spirometer. And they get a graph that ends up looking like this. Obviously, something is wrong. We could see that the forced vital capacity is not nearly as high as it should be. This slope that goes up to the force vital capacity represents how quickly the air is moving out. So really, they're just about as quick to get to their forced vital capacity as a normal patient, but they are not getting enough air through. And the volume of air for the forced expiratory volume is much, much less. That would be this value right here. So what would this graph indicate? It would indicate something called restrictive lung disease, meaning that these lungs are reduced in usable volume. They are restricted from being able to push out as much air as they normally can because they're not bringing in as much air as they possibly can. And we would say this would be reduced if it is less than 80% of a predicted normal. So those values that I had on the last graph, that would be the predicted normal, the accepted normal. Uh, and that would be for both FEV1 and FVC. We can easily take a look at these values on the graph here and see that if this is, let's say, 100% FEV1, well, if I just go down to about here, that's 3/4 up the way, and that's 75%. That would be less than the 80% that we need to be able to say that this is a normal value. Additionally, the FVC is only about 3/4 of the way up as well, and that would be 75%. Again, anytime you see these graphs on a problem that I'll give you, you will be able to compare to the normal on the graph as well. Now, some causes for restrictive lung disease where the lungs are not able to bring as much air in as they possibly need to, and therefore can't breathe out as much as they possibly can be twofold. We can have pulmonary causes and we can have non-pulmonary causes. So, for example, if I think about pulmonary causes, I'm thinking about things that are affecting the lungs directly. And this could be something such as pulmonary fibrosis, which is the breakdown of the fibers in the lungs, the stiffening of those fibers, the damage to those fibers. Pneumoconiosis, I'm not too familiar with that, but I know it has to do with a fluid that gets into your lungs and stays there for quite some time, causing swelling in your lungs, causing the lungs to not be able to expand and shrink properly. A pulmonary edema is one specific area in which your lungs is collecting fluid. A pneumonectomy is a removal of lung tissue, whether it's just one lobe or a couple lobes or even a whole side. This would be likely something that would happen if someone were to have very aggressive cancer in their lungs. And speaking of, lung tumors can restrict the amount of lung flow, the lung volume that's available because they take up that space inside the pleural cavity. However, there are non-pulmonary causes that are going to lead to this restrictive lung disease general diagnosis. We can have skeletal abnormalities, which manipulate the amount of space around the lungs and therefore restrict the amount that the lungs can move. Same goes for neuromuscular diseases. If I have a disease that's affecting my diaphragm and causing it to not be able to contract as well as it should, then that means the pleural cavity can't expand as much as it should, and therefore it can't contract as well as it should. Obesity, if we have a high amount of fat within the body and that pushes against the diaphragm or causes a bunch of weight on our chest, that would reduce the ability for my muscles to do their job to make the chest cavity open up more. And that goes for pregnancy as well. Sometimes individuals can experience shortness of breath in pregnancy because literally they have this mass underneath their diaphragm. Their diaphragm is not able to move down away from the pleural cavity, so the lungs cannot expand all the way. And those are your restrictive lung diseases. And we can see this quite easily on the graph, and you might be able to see this on problems that I have for you in the future. But really, it is just a reduced vital capacity that leads to a reduced FEV1 as well.